Hi kids, welcome back to my channel. I'm trying to make pathology simplified. So in this video, I wanted to let kids know what do we do in pathology? What exactly is the whole hakam bakam? What is the whole shebang? Exactly what we do and how we do it and how do we correlate with the surgeons and the radiologists, right? So I wanted to show you the inside of the department in a way you can say. I'm talking about neoplastic conditions, right? So surgical perspective. The branch is called surgical pathology or tumor pathology, right? Which includes both benign and malignant and further molecular investigations as well. Patient, they are living their life and they find a lump in somewhere from head to toe in their body. They found a lump. Some lumps are not exactly, discovered as lump because, internal organs. What happens is the patient will experience some symptoms which point out to the surgeon or the clinician that this organ needs to be tested. So whether through examination or clinical suspicion because of the symptomatology, the surgeon, the clinician will recommend a radiology. Radiology and pathology are like sister branches. Both of them are diagnostic. Radiology gives clinician the idea that what you were suspecting is wrong or right, the track is right or wrong. It doesn't confirm it. Confirmation, as we know, is coming from pathology only. Now the radiologist has given a report where he's saying that the lesion is benign, whether it is malignant, sometimes non-mass lesions can be there. So now what the surgeon will do, they will do a biopsy. Right? So in most of the cases from head to toe, wherever there is a lump, benign or malignant, whatever they're suspecting, they want to first do biopsy. Sometimes people also do go for FNACs depending on the setup, right? But biopsy is better because we have histopathology, because on FNAC you cannot confirm invasion, even just the cells that you're seeing. So but in histopathology, you see the entire tissue architecture in relation to the surrounding adjacent structures, whether it is invading or it is not invading, right? So we want to know that. So that is why biopsy will always be preferable. Also on biopsy, you can do additional techniques like IHC vagera, molecular vagera. On the blocks of biopsy, you can do. Now what is happening, that vial in which the clinician has sent the biopsy that comes to us, they want us to give a diagnosis, that it is benign or malignant, whether their suspicion was correct or incorrect, what kind of cancer it is, what grade it is suspected, and whatever. For every biopsy, we have a strict CAP protocol according to which we report. For every organ system, we have that reporting system. For biopsy or whether further after that, the surgeon will do surgeries and that specimen have to be reported according to the CAP protocol, which is College of American Pathologists, and that is a standardized criteria that globally is followed. Now, I have reported this is malignancy. Now, biopsy one day it can take. But for a specimen, it might take like a week or 5 to 7 days. But regular histopathology processing is done. I've switched off the fan because the noise will come in the video, and now I'm sweating. Coming back, now I'm looking at the slide. I give the diagnosis, whether this is benign or malignant. The patient will take that report to the clinician, the surgeon. Now the surgeon will decide what they want to do, what procedure they want to do. For example, in breast, they want to do WLE, whatever. So for every organ system from head to toe, we have several types of surgical procedures, and it is incumbent upon the surgeon what kind of procedures they want to do for that particular organ, for that particular malignancy or benign condition, whatever excision they have to do, or they have to remove the entire organ, what margins they have to give. It's a whole thing, and along with that, they have to remove lymph node also, especially in breast or pelvic region tumors. Now the specimen has come to us. Again, it has to be a formalin fixed specimen, and then we process it and we report it. On the day of the surgery, this specimen has come to us. We would want to ensure that the surgeons have sent the specimen in formalin. No matter the absence or presence of formalin from their side, we are going to add formalin. 10% formalin we use for our histopathology fixation. So if it is a big tissue, you do bread loafing or cutting, depending on the specimen. If it is fixation, dehydration, clearing, the whole process of histopathology is followed. After that, the paraffin block is ready, section is cut, stained, and slide comes to us. Now again we report it, it's a big report now, that's why, and the whole processing also takes time, so that's why a specimen can take from 5 to 7 days of reporting. According to that, the surgeon will decide whether they want to do if it is a benign lesion, there was nothing more to do, just observation and follow up. If it's a malignant lesion, the surgeon will have to decide what kind of radiation they want to do, and the dose and all that is decided by the radiation oncologist. So that is what happens in all the departments when they collaborate together. And most of big hospitals, they have tumor boards where if it is a complicated malignancy, if it's a complicated case, it is discussed with all the branches present, and everybody discusses the case. Everybody gives their perspective and their point of view, and further management has to be decided. Sometimes it's just palliative care or any kind of therapy that has to be given. So that was all. I just wanted you to know what happens in a pathology lab. This is not like the typical theoretical histology aspect that I'm showing you. It is just a brief introduction, because MBBS kids have been approaching me whether they should take pathology or not. So I wanted you guys to know how the whole system works, because I remember when I was doing MBBS, I had no idea what is happening in pathology, what do they do, and so this is how we go about it. The surgeon is sending, so we need the clinical history, we need how long the patient was having symptom, what other symptoms was having, does he have any history, family history, etc. Definitely we want the radiology correlation as well, and we want that investigations to be sent. In most big hospitals in metro cities, at least, you will have an electronic setup where the surgeons have written their history, the radiologist has written, uploaded their report along with pictures and everything. As a pathologist, you can just check that all out, correlate with it, and upload your report and upload your diagnosis. What do you think it is? But in government colleges, of course, you have to go after the patient and you have to call your co-residents again and again. Tell me the history, what was the history, and you have to ask the patient again. As a pathologist also, you have to engage more with the patient, and you have to, of course, ask them, radiology ki report chahiye, radiology ki report chahiye. So, because correlation is important. Without that, pathologists can be helpless at times. We need, as much as the correlation word is a joke, I understand that's a running gag. Pathology needs clinical correlation and radiological correlation to give the gold standard confirmatory diagnosis of anything, whether it is benign or malignant, what stage it is, what grade it is, and everything. So that was all about the video. Sorry for sweating so much. Thank you for watching. Let me know if there is something else that you're curious about, and in terms of the pathology field, I'll be sure to make a video on that. Bye.